morning to one and all present here. The topic of my seminar is development of hard and soft palate. So palate in vertebrate anatomy is a roof of the mouth which separates the oral and the nasal cavities while also aiding in speaking and swallowing. It plays a significant role. These are the contents. So, growth has many definitions given by various clinicians. For example, according to J.S. Huxley, it is the self-multiplication of the living substance. According to Moss, it is change in any morphological parameter which is measurable. And according to Moyers, it is a development refers to all the naturally occurring unidirectional changes in the life of an individual, from its existence as a single cell to its elaboration as a multifunctional unit terminating to death. Growth can be broadly subdivided into prenatal growth, postnatal growth, maturity, and old age. In prenatal growth, there are three, it is divided into three, which is the period of ovum from the time of fertilization till 1 week, the period of embryo from 2nd week till 8th week, period of fetus from 9th week onwards till birth. So the first phase, which is the period of ovum, it is a period soon after fertilization when the fertilized ovum undergoes mitosis. This phase lasts from conception to 2 weeks. There is formation of morula and then blastocyst. Implantation of the blastocyst to the uterine wall occurs. The second phase, which is the period of embryo, it's from 2nd to 8th week. Here, the germ layers are formed during this phase. The placenta and major body systems are also formed. The third phase, which is the period of fetus, it's the period from 9th week to birth. There are the various organs undergo further growth and development. So fertilization results in the formation of a new cell called the zygote. Then cleavage occurs in the zygote as it moves through the uterine tube and leads to the formation of a morula. The fluid seeps into the morula, which results in realigning of the cells to form a fluid-filled hollow ball called the blastocyst. As blastocyst further develops, the embryoblast differentiates into two-layered germ disc, that is the upper layer ectoderm and the lower layer endoderm. Some ectodermal cells along the central axis near the tail end of the disc proliferate to form an elevation called the primitive streak. The anterior rostral end of the primitive streak forms the lower germ layer, which is the endoderm. It mainly forms the inner lining of the organs. The prospective mesodermal cells migrate to the epiblast through the primitive streak to form the middle germ layer, which is the mesoderm. It forms the organs. Cells remaining in the epiblast form the ectoderm, thus completing the formation of three germ layers. Coming to the postnatal growth. So a pattern in growth represents proportionality. It refers not just to a set of proportional relationships at a point of time, but to a change in these proportional relationships over time. Different organs grow at different rates and at different times. So, according to Scammann's curve of growth, the lymphoid tissues attain a 200% growth by the age of 10 and then regress afterwards. Neural tissue attain full growth by the age of 6 and then stop. General somatic tissues follow a sigmoid pattern. Genital tissue grows significantly only at puberty and achieve full growth at about 20 years of age. The cephalocaudal gradient of growth. This means that there is an axis of increased growth extending from the head towards the feet. At about third month of intrauterine life, the head takes up to 50% of total body length. By the time of birth, the proportion of head decreases to 30%. This proportion steadily declines till in adult, the proportion of head is only 12%. Variability known to individuals with the exceptions of Siamese twins are alike. Hence, it is important to have a normal variability before categorizing people as normal or abnormal. Timing of growth. One of the factors for variability is growth. Variation in timing arises because the biologic clock of different individuals is different. It is influenced by genetics, sex, physique, environment, etc. Coming to pharyngeal arches, after the formation of the pericardium and the developing brain bulge and separation of the stomatodeum from the buccopharyngeal membrane, a series of mesodermal thickenings appear on the cranial-most wall of the foregut. These are called the pharyngeal or the brachial arches. These arches are seen as six cylindrical thickenings that expand and pass beneath the floor of the pharynx and approach the anatomic counterparts of the opposite side. The first pharyngeal arch is called the mandibular arch and the second the hyoid arch. The fifth arch is transient and disappears soon. The formation of the brachial arches results in progressive separation of the primitive stomatodeum from the developing heart. The endodermal extension is called the pharyngeal pouch and the ectodermal extension is called as the pharyngeal grooves or clefts. The developmental phase starts in early 4th week to 12th week of the intrauterine life. So during the 4th week of development, the mesoderm covering the developing forebrain proliferates downwards to form the frontonasal process. The pharyngeal arches grow laterally and ventrally in the most cranial part of the foregut. Each mandibular arch forms the lateral wall of the stomatodeum. This arch gives off a bud from its dorsal end. This bud is called the maxillary process. It grows ventromedially cranial to the main part of the arch, which is now called the mandibular process. The ectoderm overlying the frontonasal process shows bilateral localized thickenings above the stomodium. These are called the nasal placodes. These placodes soon sink and form the nasal pits. The formation of these nasal pits divides the frontonasal process into two parts, which is the medial nasal process and the lateral nasal process. The medial nasal process of both the sides with the frontonasal process give rise to the middle portion of the nose, the middle portion of the upper lip, and primary palate. The palate is formed by contributions of the maxillary process, the palatine shelves given off by the maxillary process, and the frontonasal processes. As the palatal shelves grow medially, the union is prevented by the presence of the tongue. Thus, initially, the developing palatal shelves grow vertically downwards towards the floor of the mouth. The primary palate is formed by the fusion of the two median nasal processes of the frontonasal process at a deeper level, and it forms a wedge-shaped mass of the mesenchyme. This part of the palate derived from the frontonasal process, it forms the premaxilla or the primary palate. Sometime during the 7th week of intrauterine life, a transformation in the position of the palatine shelves occur. They change from a vertical to horizontal position. Each maxillary process then grows medially to give rise to hook-like projection, which is the palatine process. These palatine processes then grow towards each other and fuse to form the secondary palate. The mesoderm of this palate then ossifies to form the hard palate. The ossification of the palate occurs from 8th week. This is an intramembranous type of ossification. The palate ossifies from a single center derived from the maxilla. The mid-palatine suture ossifies by the age of 12 to 14. The definitive or the permanent palate is formed by the fusion of three parts, which is the fusion of palatal process of maxilla with the primitive palate, which is in a Y-shaped manner, the fusion of both the palatine processes of maxilla, and the fusion of palatal process with the nasal septum. Here, the medial edges of the palatal process fuse with the free lower edge of the nasal septum, thus separating the two nasal cavities from each other and from the mouth. Soft palate. Ossification does not occur in the most posterior part of the palate, giving rise to the region of the soft palate. The myogenic mesenchymal tissue of first, second, and fourth pharyngeal arches migrate into this region, supplying musculature of the soft palate. Coming to the histological aspect of the development, for the fusion of palatine shelves to occur, elimination of the epithelial covering of the shelves is necessary. And to achieve this fusion, DNA synthesis ceases within the epithelium some 24 to 36 hours before the epithelial contact. Surface epithelial cells are sloughed off as they undergo physiological cell death to expose the basal epithelial cells. These cells have the carbohydrate-rich surface coat that permits rapid adhesion and the formation of the junctions to achieve fusion of processes. A midline seam is thus formed of two layers of the epithelial cells. This midline must be removed to permit ectomesenchymal continuity between the fused processes. The growth of the seam fails to keep pace with the palatal growth so that the seam first thins and then breaks down into discrete islands of epithelial cells. The basal lamina surrounding these cells is lost and the epithelial cells transform into mesenchymal cells. Coming to the postnatal growth, the growth occurs at the pterygopalatine suture. Bone remodeling of palate results in its downward displacement. The growth of the palate exhibits a V pattern of growth. The anatomy of hard palate. It forms a partition between nasal and oral cavities. The anterior two-third is formed by the palatine process of maxilla. The posterior one-third is formed by the horizontal plate of palatine bones. Anterolaterally, it is continuous with the alveolar arches and germs. The posterior and germs and gums. The posterior margin gives attachment to soft palate. The superior surface forms the floor of the nose. The inferior surface forms the roof of the oral cavity. The histology of hard palate. It is made up of thick orthokeratinized stratified squamous epithelium. The portion with rugae and raphe is pink, immobile and firm. It is a masticatory mucosa. Anterolaterally, submucosa contains adipose tissue. Posterolaterally, it contains the glandular tissue. No submucosa is seen in the palatal raphe region. Classification of hard palate according to Bernard Levin, flat form, which offers a reduced resistance to lateral and rotatory forces. Rounded form, it offers the best resistance to vertical and lateral forces. U-shaped form, it is ideal for both retention and stability of denture. V-shaped form, where the retention is less as the peripheral seal is easily broken. According to its depth, it can be flat, regular, or deep, according to the inclination, superior, parallel, or inferior, and according to the presence of bony projection, present or absent. Coming to its innervations, the arteries present are the greater palatine branch of maxillary artery, veins, the pterygoid plexus of veins, nerves present are greater palatine and nasopalatine branches of the pterygopalatine ganglion suspended by the maxillary nerve. Lymphatics, it drains into the upper deep cervical nodes and partly into the retropharyngeal nodes. Coming to the anatomy of soft palate, movable muscular fold suspended from the posterior border of the hard palate. It separates nasopharynx from oropharynx and controls the passage between food and air. It has two surfaces and two borders. The anterior surface is concave, the posterior surface is convex. The superior border provides attachment to the posterior border of the hard palate, and the inferior border is free, and from its middle hangs the uvula. From each side of uvula, two curved folds of mucous membrane extend. The anterior fold, which is also the palatoglossal arch, it contains a palatoglossal muscle. The posterior fold, which is a palatopharyngeal arch, contains a palatopharyngeal muscle. The histology of soft palate, it is highly vascularized and reddish in color. It's a lining mucosa. It is made up of thin non-keratinized stratified squamous epithelium. The lamina propria shows a distinct layer of elastic fibers separating it from the submucosa. Submucosa is relatively loose and contains an almost continuous layer of mucous glands. Its innervations, the arteries present are greater palatine branch of maxillary artery, the ascending palatine branch of facial artery, the palatine branch of ascending pharyngeal artery. They pass through the pterygoid and the tonsillar plexus of veins and drains into the upper deep cervical and retropharyngeal lymph nodes. Coming to its nerve supply, the motor nerve supply, all the muscles of the soft palate except the tensor valli palatini are supplied by the pharyngeal plexus. The tensor valli palatini is supplied by the mandibular nerve. The sensory supply, the middle and the posterior lesser palatine nerves, and the glossopharyngeal nerve. Coming to its classification, according to House, Class 1, where more than 5 mm of movable tissue available for post-tamming, it is ideal for retention. Class 2, 1 to 5 mm of movable tissue available for post-tamming, it provides a relatively good retention. Class 3, less than 1 mm movable tissue available for post-tamming, here the retention is poor. Coming to the prosthodontic implication, the median palatine raphe. It's a it's a midline ridge of tissue on the hard palate which overlies bony fusion of the palate. The submucosa is very thin and non-resilient in this region, so it should be relieved. The incisor papilla, a small bulge of tissue at the most anterior portion of the hard palate. It's lingual to the anterior teeth and it serves as a rough guide in locating the anterior-posterior position of the maxillary teeth, which is around 8 to 10 mm. The incisor foramen, it is located beneath the incisor papilla. It lies nearer to the crest of the ridge. As resorption progresses, it should be relieved. The palatine rugae, they are firm irregular ridges of tissue radiating from the papilla and the raphe. It acts as a secondary support area. Coming to the posterior palatal seal area, a soft tissue area at or beyond the junction of the hard and soft palate on which the pressure within the physiological limits can be applied by the denture so that it aids in retention. This PPS extends medially from one tuberosity to another. Laterally, the pterygomaxillary seal extends through the pterygomaxillary notch, continuing for 3 to 4 mm anterolaterally and approximating the mucogingival junction. The PPS area lies between the anterior and the posterior vibrating lines. The anterior vibrating line, it is an imaginary line located at the junction of the attached tissues overlying the hard palate and movable tissues of the immediately adjacent soft palate. It is created by asking the patient to perform the Valsalva maneuver. The posterior vibrating line, it is located by visualizing the area while instructing the patient to say "ah" in short bursts in a normal, unexaggerated fashion. The direction of the vibrating line usually varies according to the shape of the palate. The higher the vault, the more abrupt and forward is the vibrating line. In a mouth with a flat vault, palatal vault, the vibrating line is usually farther posteriorly and has a gradual curvature, affording a broader posterior palatal seal area. The functions of PPS include retention, provides a close contact of denture base with the mucous membrane. It provides a firm contact of the denture base with the tissue, and this diminishes or eliminates gagging. It supplies sunken distal borders which are less conspicuous to the tongue. Coming to phonetics, so the production of speech sound consists of the coordinated and synchronized movements of an estimated around 160 muscles. And these include such as the lip, tongue, and the overall shape of the vocal tract. In a phonetic perspective, speech sounds are typically described in terms of their manner and place of articulation. For example, in plosives, the airflow through the vocal tract is fully blocked, which is by placing the tip and the sides of the tongue against the roof of the mouth. It gives rise to sounds such as P, T, K, B, D, and G. In fricatives or the linguoalveolar sounds, the tongue is raised and approximates the palate to such a degree that a very small opening remains for the airflow to escape with a clear hissing sound quality. For example, in sounds such as F, S, V, Z, and in resonants, which are the lingopalatal sounds, the tongue is also raised from its neutral position towards the palate, but the gap remains relatively big so that the airstream does not become turbulent and with sound without hiss. For example, J, W. Coming to a palatogram. A palatogram is a fairly simple yet highly efficacious technique of assessment and verification of palatal contours so as to improve and correct the existent speech deficiency of affected sounds. In the present case report, readily available food color in spray form was employed to produce and investigate inadequacies of various sounds. So, a 52-year-old male patient, upon eliciting past dental history, he revealed of getting rehabilitated with complete dentures in the Department of Prosthodontia a month ago with satisfactory aesthetics and functions. However, he continued to have speech problems with regards to the pronunciation. His altered speech was a matter of grave embarrassment for him as it reflected in his undermined performance while delivering lectures. So a palatogram of the sounds were generated by the action of the tongue, wiping away the sprayed color film, forming a definite pattern during speech. So the palatograms for S and T sounds were taken. Here, the red outlined area shows under-contoured palate, while orange outlined shows over-contoured, and violet outlined area shows under-contoured part of the palate. So corrections are made where as in an over-contoured area, there is selective trimming is done, and in under-contoured, a tissue conditioner was applied. These are the verified palatograms after doing the correction. So coming to the habits which affect the palate, thumb sucking habit. Here we can see clinical features such as anterior open bite, there's an increased overjet, proclined maxillary anterior teeth, and narrow maxillary arch can be seen. In mouth breathing, a narrow nose and nasal passage is seen, a contracted maxillary arch, posterior crossbite, short, flaccid upper lip, and there's an increased overjet. So the different developmental anomalies or pathosis of the palate are the tumors of the palate, Paget's disease, torus palatinus, lymphatic aggregations, necrotizing stylometaplasia, pigmentation, congenital defects such as cleft lip and palate, inflammatory regions such as chronic papillary hyperplasia. Coming to clefts, a cleft lip, it is basically the presence of one or two vertical clefts in the upper lip, resulting from failure of the normal process of fusion of the lip to come to a completion during embryonic life. And a cleft palate is an opening in the roof of the mouth due to a failure of the palatine shelves to come fully together from either side and fuse. The demographic details, the incidence of cleft lip and palate is 1:600 live births, and isolated cleft palate is 1 in 1000 live births. The Negroid race has the least incidence, the Mongoloids have the highest incidence. The cleft lip and palate is mostly seen in males, and isolated cleft palate cases are mostly seen in females. Among the unilateral clefts, the left side is seen in 70% of the cases. Coming to its etiology, heredity. So this is considered as an important etiologic factor as it can be, and it is transmitted as a dominant or a recessive trait. And the genes involved in this are the transforming growth factor alpha, transforming growth factor beta 3, and MSX1 gene. This can be syndromic and non-syndromic. The syndromic forms are due to the chromosomal aberrations or the monogenic diseases, example Van der Waals syndrome. And the non-syndromic cleft is a multifactorial disease derived by the interaction between the genetic and the environmental factors. Coming to the environmental factors, which include womb environment, external environment, nutrition, drugs. Some of the known teratogens include talantin sodium, valproic acid, valium, methotrexate, mercaptopurine, cortisone, or few viruses such as the rubella virus. The other predisposing factors are the increased maternal age, racial and blood supply to the fetus. The embryologic causes of development of a cleft palate are maybe it can be due to the failure of palatine shelf formation, failure of palatal shelf elevation, failure of growth of the palatal shelf, failure of the palatine shelves to fuse. The classification of cleft lip and palate according to Davis and Ritchie. Group 1, which is the pre-alveolar clefts. Here lip clefts only with subdivisions for unilateral, median and bilateral. Group 2, which is the post-alveolar clefts. Degrees of involvement of soft and hard palate to be specified till the alveolar ridge. Submucous clefts are included. Group 3, alveolar clefts, is a complete clefts of palate, alveolus and lip with the subdivisions for unilateral, median and bilateral. Views classification. Group 1, clefts involving only soft palate. Group 2, clefts involving hard and soft palate and extending up to the incisor foramen. Group 3, unilateral clefts involving soft palate, hard palate, lip and alveolus. And Group 4, complete bilateral cleft involving soft palate, hard palate, alveolus and lip. Kernahan's stripped by classification. Here each block represents a specific area of oral cavity, where 1 and 4 are lip, 2 and 5 are alveolus, 3 and 6 are hard palate anterior to the incisor foramen, 7 and 8 is the hard palate, 9 is the soft palate, and O represents the incisor foramen. The Millard's classification. It's a modification of Kernahan's stripped by classification. Here the inverted triangles represent the nasal arch and the upright triangles represent the nasal floor. The LAHSAL classification. It is a paraphrase of the anatomical areas affected by the cleft, where L represents here the lip on the right side, alveolus, A for alveolus on the right side, H for hard palate, S for soft palate, and A for alveolus on the left side and L for lip on the left side. The problems encountered in children with cleft lip and palate are feeding problems, defective speech and hearing, missing supernumerary or hypoplastic teeth, malocclusion, psychological problems, or could be gross facial deformity. This is the multidisciplinary approach for a cleft lip and palate patient. It includes the patient care coordinator, a pediatrician, maxillofacial surgeon, orthodontist, pediodontist, prosthodontist, psychologist, a genetic counselor, a plastic and reconstructive surgeon, speech therapist, audiologist, and an ENT specialist. The role of a prosthodontist in cleft lip and palate in the pre-surgical phase is by giving feeding plates to the neonates, providing a palatal obturator to the patients prior to surgery. In post-surgical phase, immediate post-surgical prosthesis or an obturator, a palatal obturator, dental implants, ear, eye, nose, and other facial prosthesis, speech aid prosthesis for better speech of cleft lip and palate patients, replacement of teeth for better aesthetics, and mastication. The treatment plan. In stage 1, which is the maxillary orthopedic stage, it is from birth to 18 months. Here the management of feeding problems is done, which includes the initial obturator therapy, pre-surgical orthopedics, and the surgical lip closure is done. Here the feeding problems can be effectively dealt with by using appliances like plate, pumps, and nipples. The initial obturator therapy is from birth to 3 months. The appliance is fabricated after taking impression and it is made of acrylic. In pre-surgical orthopedics, it is from birth to 5 months. It aims to achieve an upper arch form that conforms to lower arch form. This can be accomplished by retraction plate or pre-maxillary retraction tape, where it is difficult for surgical lip closure. This is the Millard's repair, View's repair, and Terence and Randall repair. So the surgical lip closure is done from 3 to 9 months. The best time for lip repair, as a lip is not much developed and vermilion border are very conspicuous. The rule of 10 is an important criteria for lip repair. It states that at the time of surgery, the age of the child should not be less than 10 weeks of age. have no less than 10 gram% of hemoglobin, and weight should be at least 10 pounds. Coming to surgical palatal repair, which is from 10 to 18 months, it can be of two types. These are the single stage, the von Langenbach palatoplasty and the VY pushback palatoplasty. They are carried out at 1.5 years. The disadvantages here include a midfacial growth retardation, the two-stage repair of the soft palate is done around 18 months, and then hard palate at 4 years. Stage 2, which is the primary dentition stage, is from 18 months to 5 years. Here adjustment of the obturatus is done, the restoration of decayed teeth, the maintenance of oral hygiene, and the erupting dentition is evaluated. Stage 3, which is the mixed dentition stage, correction of the cross bites, secondary bone grafting is done. Stage 4, the permanent dentition stage, where a fixed orthodontic treatment is given and cosmetic repairs such as rhinoplasty, etc. is done. So the biomaterials used for cleft lip and palate regeneration. Biomaterials play a key role in the tissue engineering strategy for the restoration of missing tissue and its functionality. In particular, the advances in bone regeneration using biomimetic 3D scaffolds made of bioceramics, polymers, and composites using different manufacturing methods, scaffolds made of, that is 3D printed, cryopolymerization, etc., have permitted the exploration of new options for the repair of tissues in cleft lip or palate treatment. Impression taking in cleft patients. A proper patient and dentist position are vital to avoid excessive tissue displacement in heavily scarred areas. The most adopted positions are the prone, face down, upright, and upside down. Selection of the tray. The tray should have enough size transferably to include the lateral maxillary segment and posteriorly cover up to the maxillary tuberosities. This provides a good reproduction of mucobuccal folds. The rimming of the entire tray with utility wax is done so as to avoid sharp edges, provide post-stamp, and provide an additional bulk of material laterally. Materials used for impression. Heavy body silicone impression material, polyvinyl siloxane impression material, low fusing impression compound, and alginate. Complications which can occur are difficulty in removal of the impression due to the engagement of the undercuts, the fragmentation of the impression during its withdrawal from the mouth, respiratory obstruction due to its lodgement in the respiratory passage, cyanotic episodes due to asphyxiation. Precautions: use of dental mouth mirror, clean cotton tipped earbuds. Impression should be taken in a hospital setting. Impression made when the infant is fully awake without anesthesia pre-medication. The absence of crying may be indicative of airway blockage. High volume suction should always be ready. Preferably no feeding at least 2 hours prior to the procedure. Coming to the nasoalveolar molding. The pre-surgical nasoalveolar molding was introduced to reshape the alveolar and nasal segments prior to surgical repair. The first pre-surgical nasoalveolar molding appliance was designed by Grayson et al. In 1999. This works on the principle of negative sculpturing, which is a serial modifications are made on the internal surfaces of the molding appliance with addition or deletion of material in certain areas to get desired shape of the alveolus and nose. And second principle is by passive molding, where a custom-made molding plate of acrylic is used gently to direct the growth of the alveolus to get the desired result later on. The impression technique. The initial impression is made using heavy-bodied silicone impression material. It should be taken soon after birth as the cartilage is plastic and is moldable. Infant is in upside-down position. The impression material is allowed to set and then the tray is taken out of the infant's mouth. The mouth is checked for remaining impression material. A cast-on model is poured with a dense plaster material, or which is the dental stone. The plate is made up of the stone, is made on the stone model. The undercuts present on the cast are blocked out with utility wax, separating media is applied. The NAM plate described by Grayson and Moll is prepared up of hard and clear self-cure acrylic. It is lined with a thin layer of denture soft material. The retentive taping and buttons. The retentive button aids in retention of the molding plate. It is fabricated at 45 degrees from the horizontal occlusal plane. The retentive tapes should be applied to the infant's face to retain the appliance. The elastics used should have an inner diameter of 0.25 inch and it should be stretched out 2 times the diameter of activation force of about 2 oz. One retention arm is used in cases of unilateral cleft only. It is positioned approximately 45 degrees down from the horizontal to achieve proper activation. Coming to the appliance adjustment, the appliance is left for 24 hours in mouth and parents are instructed to remove it only for cleaning purposes. After 24 hours, the patient is recalled to evaluate and correct sore spots or other problems with the appliance, if any. The recall appointments are scheduled weekly to modify the molding plate by selective trimming and addition of the acrylic to direct the alveolar fragments into the required location. The nasal stent. The incorporation of a nasal stent is recommended when the alveolar flap width is decreased to 5 mm. It is made up of 0.036 gauge round wire and resembles kidney shape. It is added to the vestibular shield of the appliance. The timing of the wear. On average, a unilateral cleft will require the NAM for around 3 months, while a bilateral baby might be required to wear it up for 5 to 6 months. Post-insertion evaluation. Observation is done for retention, posterior extension, verification for not too tight fitting, and no acrylic in cleft area. The infant suckling evaluation is done and checked for gagging. The follow-up is on weekly basis. Progress of molding appliance is monitored. Retention is evaluated. Examination for possible source. Monitor changes in size of defect. Modification of appliance if needed. So the initial presentation of nose or lip deformity in bilateral cleft lip and palate. Note the hypoplastic columellas, splayed nasal domes, and alar wings, and an inferior location of the nostril apices. Typical appearance of the nose following treatment with nasoalveolar molding. Note the elongated columella, improved nasal tip projection, corrected alar wing position, and improved nostril aperture orientation. View of a patient after primary retrograde nasal construction of correction of the lip and alveolar deformities. So before NAP, we can see absence of tissue at bone of nose. Tip of the nose loses its projection. This deviation of columella, medial aspect of greater alveolar segment is often displaced slightly superiorly. And after nasoalveolar molding, there's an increase in nasal tip projection, improved nasal symmetry, alveolar cleft lip is closed, increased surface area of nasal mucosa lining facilitates surgical repositioning and retention of nasal tip cartilage. Complications which can occur are blocked out segment, nostril overexpansion, failure to retain appliance, tissue ulceration, skin irritation, exposure of primary tooth. Coming to palatal obturator, it is a process used to close a congenital or acquired tissue opening, primarily of hard palate and contiguous alveolar structures. It includes surgical, interim, definitive obturator. It is used to cover an open palatal defect basically. Its uses are it provides a stable matrix for surgical packing, it permits deglutition, reduces the psychological impact of surgery, and aids in speech. A palatal obturator consists of an acrylic body that looks similar to a dental retainer. However, it has additional acrylic extension superiorly which should fit perfectly into the area of deficiency. A palatal lift process, however, is a special type of obturator which is a definitive processes with a posterior extension. It helps in restoring palatal pharyngeal incompetence. This is a pharyngeal bulb prosthesis given to a patient. It is given to a patient having a velopharyngeal incompetence. Here we can see a nasoendoscopic view of before and after the placement of the prosthesis. A retainer-free obturator processes in a fully dentulous patient. So this is a case report of a 57-year-old woman who had a chief complaint of nasal congestion. A myoepithelioma of palate was diagnosed and maxillary bone and palate resection was planned. A retainer-free obturator processes was inserted. The obturator portion extends upward along the outer edge around the defect and is not in contact with the nasal septum. The processes consisted of a palatal plate and hollow obturator portion with a resilient silicone layer over a resin frame. So this is another clinical report of a full arch monolithic zirconia processes in a patient with bilateral cleft palate. A 34-year-old man with bilateral cleft palate and a failing dentition presented to the prosthodontist seeking fixed prosthetic solution. The treatment involved using 5 dental implants and 1 piece complete arch fixed implant supported processes made of monolithic zirconia. This is the occlusal view after uncovery and connection of multi-unit abutments on posterior implant, the submerging midline implant and mobile premaxilla. The second image shows a rigid splinting of all 4 impression copings before making definitive impression. A screw-retained milled prototype resin process is connected to midline implant chairside to splint mobile premaxillary segment by using composite resin. During polymerization of composite resin, patient performed physiological movements to position the premaxilla in most comfortable position. This is the monolithic zirconia processes, frontal and occlusal view. This zirconia process is aided in rigidly splinting not only the implants but also in orthopedically splinting the mobile premaxillary segment to the maxilla. The other syndromes involving the cleft lip and palate include the van der Waals syndrome, Treacher-Collins syndrome, the Perry-Robin sequence syndrome. So to conclude, it is important to understand the development of oral and maxillofacial structures and the timeline of events in the process so as to know the different treatment modalities present which could be provided to the inpatient's best interest. These are my references. Thank you.